Hello, everyone. I hope everyone can hear me. Um, Thank you for joining us this afternoon. I'm just going to wait a minute just to make sure that everybody can hear me. So maybe some of you can just give us a bit of feedback whether everything sounds okay. Excellent. Right. So a few people have responded, which is great. I apologize. I'm new to this Zoom seminar thing, but I'm sure we can make our way through. Again, thanks for joining us this afternoon. My goal this afternoon is to cover basically the emergent management of patients during this pandemic. If you have questions, please feel free to send them along. I will try my best to answer as we go along, and at the same time try and navigate this. Now my screen's frozen. What's going on here? There we go. So the objectives for this discussion are going to be the definition of what an emergency is, how to triage these emergencies, the management of the emergency, and specifically I will cover the pharmacotherapy, which is the first line, and then I will touch on if you cannot manage it, what the referral process should be. I will also overview the requirements for the personal protective equipment depending on the type of situation. So in a nutshell, the RCDSO has defined an emergency as something that is related to orofacial trauma. Sorry, I got a message saying the text is tiny. I'm not sure how to make that bigger.
So for the text being tiny, you should be able to drag. There should be a little two bars that you can drag to make the screen either side bigger or smaller.
Bars.
It should be right in between the two screens. And so that's for each participant, sorry, not for you, Dr. Alibhai.
Oh, okay.
Yeah, so each participant can move it bigger or smaller depending on what works for them.
Okay. So the guidelines according to the RCDSO for emergencies basically falls in 4 categories: orofacial trauma, significant infection, prolonged bleeding, and pain that's not managed by over-the-counter medications. So the first step with regards to the emergency is either the dentist's office or the dentist is going to call it, or the patient themselves are going to give you a call. The majority of these, unfortunately, have to be managed initially either over the telephone or some sort of web chat like FaceTime or teledentistry, whatever is comfortable for you. The important point to note about that modality is you need to inform the patient that this is a non-secure method, just to cover, acts of privacy and whatnot, because depending on if you're using email or FaceTime or something like that, you want to try and make sure that you're not talking about a patient with other people around or anything like that. Again, just to cover any privacy issues with regards to doctor-patient confidentiality. The second thing is you would do your routine triaging, such as trying to elicit what the problem is, when the problem started, what they have done on their own to try and manage the problem, and basically your normal criteria that you would have to follow through during a emerge consultation to try and elicit all the information that you think is pertinent to try and come to a diagnosis. Important part of the initial consultation is to figure out whether the patient has had symptoms of COVID-19, i.e. such as fever greater than 38 degrees Celsius, whether they have a cough, whether they have a sore throat, whether they've experienced any sort of difficulty issues, breathing issues with regards to the current situation, whether they suffer any flu-like symptoms, like watery eyes, runny nose, cough. And all of these things, again, are just to try and get a gauge whether they potentially could be COVID positive. You want to also try and elicit whether they've had any COVID risk factors, such as, have they been in contact with anybody that potentially could have the virus or have been exposed to the virus without you yourself having any sort of protective equipment on board. Also, you want to make sure that, do they have any sort of travel in the last 2 weeks to make sure, are they supposed to be self-quarantined or not? And they're breaking that also to minimize the risk potentially to yourself and to your staff should you need to see them. After going through the consultation, the various questions, and eliciting whether they have any COVID symptoms or COVID risk factors, it should give you an opportunity to hopefully formulate a diagnosis, and also should give you an opportunity to formulate whether they have a risk of COVID transmission or not. And slide's not advancing, come on. Oops, there we go. Sorry. So after you've formulated a diagnosis, if possible, the first line should always be some sort of pharmacotherapy. Whether you deem based on your working diagnosis, they require an antibiotic, or whether they just require an analgesic, or do they require both? If you put them on pharmacotherapy, it's also important to make sure that you follow up with them and monitor them to make sure that they continue to remain symptom-free and the pharmacotherapy that you have prescribed is keeping them comfortable, okay? If after the pharmacotherapy, everything's fine, they can return back to their normal lives, then you've done your part and there is really no need to see them unless they develop other issues. Once this pandemic is over, you can always refer back to this emergency and try and bring the patient in to further manage them based on what is required. If the pharmacotherapy initially fails, or initially it worked fine, but now the problem has come up again, and you feel further pharmacotherapy is not appropriate or relevant, then the next step is you need to decide what treatment this patient requires, be it an extraction, be it endodontic therapy, whatever you deem appropriate. Then you need to also decide, based on the treatment that you are proposing, do you have the right protective equipment in order to treat the patient to make sure that you don't put your staff and yourself at risk, or vice versa? Okay. If you have the appropriate protective equipment, then you can go ahead and manage the patient. If you do not, then the next step is you need to decide where to refer that patient. So let's go into the pharmacotherapy management. This algorithm, I think, works really well. It's a nice summary, and you can tell from the slide that actually I came across this algorithm on the Alberta Dental Association College website, and it's good because in one page, it summarizes the steps that you should go through in order to manage the patient pharmacologically, okay? So we will start on the left-hand side under pain management. If you deem that the patient requires additional pain management, The recommendation obviously is to try and manage them with over-the-counter medications, be it Tylenol or acetaminophen and or ibuprofen. That is a call that you can make. And the dosages, like I said, are listed in this in the algorithm. If you want a copy of the algorithm, you can either reach out to Sean or you can go to the Alberta Dental Association website and download it for yourself. So initially, for pain management, I would recommend an over-the-counter medication such as Tylenol and or ibuprofen. The dosages of Tylenol can vary depending on the severity of the pain. Just remember with Tylenol, there is a daily maximum of 4,000 milligrams or 4 grams per patient. You need to be cautious in patients that have liver function issues because Tylenol is metabolized by the liver. With regards to the ibuprofen arm of it, again, 400 to 600 milligrams every 6 hours, depending on the severity of the pain. And again, the only caution with anti-inflammatories, again, are, if they have kidney issues or whatnot, higher doses of anti-inflammatories for a prolonged period of time can cause some kidney issues as well. If their pain is not managed appropriately with Tylenol and ibuprofen, then the next line would be adding something like a narcotic. Initially, it'd be something like a weak narcotic like codeine or tramadol. Codeine can be prescribed between 30 to 60 milligrams every 4 to 6 hours, depending on the severity. And the tramadol, again, can be prescribed between 50 to 100 milligrams every 6 hours, depending on the severity of the pain. If additional narcotics like codeine and tramadol are inadequate, then the next step again would be to jump to something like Percocet or oxycodone. Failure of pharmacotherapy with regards to pain management, okay, then would further necessitate discussion with, for example, if it's an endodontic problem, you may reach out to your friendly endodontist and ask him or her for some advice, be it a OMF problem. You can reach out to your friendly oral surgeon and ask him or her with regards to additional options or additional advice, and try and get the patient managed. With regards to the antibiotic side, again, the first line should be a beta-lactam based antibiotic if they don't have any allergies to medications like penicillins or cephalosporins. The beta-lactams are first line. So depending on your preference, you could prescribe something like penicillin V or amoxicillin. And the dosage ranges for penicillin can be between 300 to 600 milligrams 4 times a day for 7 to 10 days, depending on how severe you think the infection might be. With amoxicillin, 500 milligrams 3 times a day for 7 to 10 days, again, depending on the severity of the infection. If they have a beta-lactam allergy, then the next antibiotic of choice would be clindamycin. And clindamycin, depending again on the severity of the infection, can range between 300 to 450 milligrams 4 times a day for 7 to 10 days. If they have allergies to a beta-lactam or clindamycin, then the other suggested antibiotic is something like a macrolide like azithromycin. You can prescribe a Z-Pak, which would involve 500 milligrams the first day and then 250 milligrams per day for the next 4 days. Another macrolide that is fairly common, third line, would be Bioxin at 500 milligrams twice a day for 7 to 10 days. They've suggested doxycycline as well. Just my personal opinion is I don't really use a lot of doxycycline. If they had an issue with something, like I said, with penicillin, cephalosporins, clindamycins, and macrolides, then normally my fourth alternative category of antibiotics would be something like a fluoroquinolone, like Levaquin, which is prescribed 500 milligrams once a day. I like Levaquin because it has more gram-positive coverage, which is more appropriate for the oral microflora. Additionally, if you want added anaerobic coverage, then you can add metronidazole to mix. Usually, if I'm prescribing metronidazole with amoxicillin, I try and prescribe metronidazole 3 times a day, just so that it makes it easier for the patient to be taking the antibiotics concurrently. The biggest issue with any medication where they need to take it more frequently during the day is compliance. The more frequently they have to take, the lesser compliance there is. So always try and make things easier for the patient. So if you like penicillin, then you can prescribe the penicillin 4 times a day. And if you need to prescribe metronidazole, you can prescribe metronidazole twice a day, so they can take the metronidazole with their penicillin dose every other dose. If you're prescribing amoxicillin and metronidazole, then I'll prescribe the metronidazole 3 times a day, just so that it makes it easier for them to take it together. The other options, depending on if you want to increase the spectrum of activity of the antibiotic, is clavulin or augmentin. It really extends because of the beta-lactamase inhibitor, clavulanic acid. It really expands the scope of the antibiotic. So clavulin or augmentin really gives you a fairly big gun in order to treat the infection. Clavulin is not something that I would go to first line, second line, or third line. It's one of the ones that I would reserve if, the antibiotic first line, something like penicillin or amox metro hasn't worked and you want something bigger, then that's what you want to use for a gun, is something like clavulin or augmentin. Again, if the antibiotic side does not resolve the issue, then your next step is to reach out to a specialist, depending on the problem, whether it be an endodontic problem or oral surgical problem or whatever it is, and try and get some help or try and get some advice to see if how you can better manage the patient. On the very bottom is a good box, basically saying that, if the facial swelling or the infection is fairly significant and includes some danger signs, i.e., such as airway obstruction, or they have difficulty opening their mouth very wide, or they have difficulty or painful swallowing. Okay, all of these things are danger signs, which mean that they require more urgent or immediate attention. This is not something that you want to sit on. And these are the types of patients that would require more aggressive management, usually done in a hospital setting. With the pandemic, they've really encouraged providers not to send their patients to the emergency department or to the hospital unless absolutely necessary. So you need really to reach out to most likely, whether it's an endodontic problem, any endo problem, if you start to run into danger signs of trismus, dysphagia, odontophagia, if they're starting to their eyes starting to shut because of infection and whatnot, this really is a very emergent situation, and I would not hesitate to reach out to the oral and maxillofacial surgeon on call for the hospital and make them aware of your patient's condition and get them involved very early on. You don't want to sit on these patients, because these patients can really take a turn for the worse fairly quickly. So just to reiterate, you can manage the majority of the patients with the algorithms provided here, but if you have any inkling that this patient could take a turn for the worse very quickly, based on the signs and symptoms listed at the very bottom of that algorithm, do not hesitate to reach out to the oral and maxillofacial surgeon on call and get their help very early on. All it takes is a phone call. They can help you manage them, right? And that's part of their responsibility. This is an algorithm for pediatric patients. Again, they're simplified to over-the-counter type medications of acetaminophen and ibuprofen with regards to analgesia, and with regards to antibiotics. they're simplified to the first two antibiotics that are suggested, which is a beta-lactam, and if they have a beta-lactam allergy, going to a clindamycin. Sean has just told me there's a couple of questions, so I'm just going to pause at this time and to answer them. So one of the question is, shouldn't we consider risk factors such as travel outside of Canada is out of date and no longer a useful screening question considering the extent of community spread that is occurring? The Public Health Agency of Canada has published online that as of April 22nd, all of COVID-19 cases are related to community transmission. Yes, that is a very good point in that the amount of international travel has been reduced significantly. However, you have to realize that, especially in Ontario, being close to the border with the US, we do get a lot of workers that are going back and forth. So again, the travel outside of Canada is not just internationally, but also to our neighbors down the south. So again, hopefully all of the answers or questions that you asked them with regards to COVID symptoms and risk factors come back negative. But again, it doesn't hurt to ask them, have they been traveling or not? Because ideally, if they have been outside of Canada, they need to quarantine themselves for 2 weeks according to the guidelines. But not everybody's going to be following guidelines, and you want to make sure that these aren't one of them. The next, hopefully that answers your question. If not, please send another question. Another question here is just to make sure if there are any signs, where you go? Oh, yeah. Just to make sure if there are any signs of dysphagia, for example, send patient to the hospital or reach directly the OMFS on call at the hospital. If yes, what is the number to reach out to the OMFS? So the answer to that question is, so you still need to initially triage the patient. So a lot of times you will get patients that complain of difficulty swallowing or painful swallowing, and that's just because they have a bad tooth and it just hurts to swallow. So you really need to ask them additional questions in that, can they clear the saliva in their mouth? Do they feel like the floor of their mouth is hard, or do they feel like their tongue is elevated? So you need to ask additional questions to decipher whether this truly is an urgent situation, or is this somebody that is just having pain because of a dental issue, okay? If after talking to them, you feel that, no, this seems to be legit, then yes, you shouldn't send them to the hospital right away unless you feel like they're in impending doom. And hopefully they are not in that situation, i.e. they've reached out to you early enough that you have some time to decipher whether this is an emergent situation or not, okay? And if you feel like, yes, I think they need to be seen, then your next best, like I said, is to call the oral surgeon on call. One of the questions is, what is the number to reach out to the oral surgeon on call? So as far as the oral surgery coverage in Ottawa, all of that is done by the oral surgeons at Argyll. So you would be best to reach out to them. I believe that their number should be on their website. I personally don't have their emergency number. Usually we try and reach out to one of their group, okay? And usually it's done through their office to find out who is actually the oral surgeon on call and have them manage the situation. It is always best to reach out to them via telephone first, unless you feel like this patient is imminently in danger. Then basically you're almost to the point of trying to get them to activate the ambulance via 911. Hopefully it doesn't come to that, okay? Hopefully it's much better to reach out to them by phone just to make sure that they're aware of it and they can better manage that situation. Again, hopefully that answers your question. If not, please send a supplemental question. The next question is, can we possibly see a recording of this? I'm gonna redirect that question to Sean, and you can reach out to Sean and he can answer that question for you. Because I
There
believe
will be a recording of this. We'll send out the recording where everyone will be able to see the slides and hear the audio.
Okay, so I'm gonna get back to the presentation because I think those are the two questions taken care of. Okay, so going back to the pediatric algorithm again, acetaminophen, ibuprofen is what they're recommending with regards to pain management, and with regards to antibiotic use, amoxicillin, and if they have a beta-lactam allergy, then clindamycin is the alternative. Okay. Same thing, there are danger zones at the bottom of the box. If they have any of those signs, same thing applies to them as there would be for the kids. You need to reach out to the oral surgeons to figure out how to better manage these in a hospital situation. Oops. So they failed pharmacotherapy. You have determined that you have the appropriate PPE, which again, I'll go over in the next few slides. Then the next step is to determine what type of procedure that you're going to provide for the patient to manage the emergency. So the procedures that generate, so aerosols are the highest risk for dental staff, dental providers, and patients because literally we're in their face. Okay. And the procedures that generate the most aerosols are the use of handpieces, ultrasonic devices, high volume suction. And someone had asked me, well, how does that make sense? Because you're using the high volume suction to try and clear the surgical area or the treatment area. And yes, that is the case. Even if you're, for example, doing a pulpectomy and you're using a rubber dam and whatnot, the way that a high volume suction creates aerosol is because the volume of the suction is so strong to try and suck up the liquid, that the surface of that liquid is actually aerosolized as the suction works. Okay, so that's how the high volume suction creates an aerosol. Air-water syringe, again, straightforward, and to a lesser extent, the low volume suction, because it's not as powerful, it does not create as much aerosol as a high volume suction. So these are the procedures that we need to be aware of with regards to what type of PPE we require. So for PPE requirements, according to the RCDSO, if they're non-aerosol generating procedures, then what you require are gloves, a surgical mask, and protective eyewear. So fairly standard equipment before even the pandemic had started. Of note, if you wear prescription eyeglasses like I do, they do not count as protective eyewear. You either need a face shield, which you can wear on top of your glasses, or you need those safety goggles that we used to wear in like chemistry class in first year university, the ones that cover all of your eyes and the side of your temples as well, because you don't want any sort of splashback or anything to come in through the side of your glasses. Okay, or you can have safety glasses that actually provide protections on the side as well. If your procedure does generate aerosols, again, so you need everything that you need for non-aerosol generating procedures. However, in addition, you also require a protective gown, okay? And a surgical mask is no longer appropriate. You need a fitted N95 mask or the equivalent. And must highlight the fitted part because going grocery shopping and whatnot, I have seen some patients wearing an N95 mask, and one of the ones I saw, they had a full beard. Well, that N95 really is not doing the job that it was designed for, because the N95 needs to be fitted to make sure that you have a good fit so you don't have any air leak. So if you are wearing an N95 that has not been fitted, you really don't know if it's providing you the type of protection that you require, because you may have break and seal somewhere along your face where the aerosols can get in. The last point that I've put in there, which is not a requirement listed on the RCDSO website. However, I would recommend that if you are doing procedures where you're generating an aerosol, that you wear some sort of a head covering, be it one of those disposable surgical nets, sort of like the ones that bakers wear, or hair nets, or if you have a surgical cap or something like that, just to cover your hair, because depending on the length of your hair as well, the aerosols can get impregnated into your hair, and this is just an additional layer of protection for you and your staff and your patients. If you don't have the appropriate PPE to provide care for your patient, then absolutely it makes sense for you to refer the patient to another dental clinic that has the appropriate PPE, or to a specialist clinic to manage the patient. If you make that referral, ideally, it's best if you can provide them with as much information as possible so that it helps them triage the patient accordingly so that they know what type of procedure is required. Also, if you have any appropriate radiographs, that would be very helpful, as data radiographs that would really be helpful so that we do not have to expose the patients to further radiation in order to try and diagnose the problem. Also, please remind the patient that this is an unusual time period and that we are limited to providing emergencies only. It is very common for me to see a referral where the referring dentist has asked me to remove a tooth and do an immediate implant. While it's great that we're already thinking of how to restore the patient's occlusion, this is not the time to do an implant. So very often we have to get back and say, thank you very much, but at this time we will only remove the offending problem. When this pandemic is over and we're back to some sort of normalcy, we can then look at restoring that edentulous space with an implant or whatever else you need. Also, please be aware that we are not seeing consultations, okay? Again, I do get referrals saying that, can you please, there's this problem, we're not sure what it is, can you please see the patient to figure out what the problem is? Unless the patient is experiencing significant pain, significant infection, significant bleeding, something along that lines, then these are not appropriate at this time. Other things that you want to consider, if you are seeing patients in your office, not only having the appropriate protective equipment is essential, but also how to put them on and take them off is very important as well. You could have the right equipment, but if you don't know how to put them on, and more importantly, take them off, then you could actually contaminate yourself as you're trying to take them off. On the Alberta Dental Association and College website, there is a nice link to an Alberta Health Services video where they actually go through the appropriate way of putting on and taking off personal protective equipment. It's approximately a 13-minute video, and I think it's very helpful. So if you're thinking of treating your own patients or treating patients of others, then it would be worth the 15 minutes just to make sure that you are putting on and taking off your personal protective equipment appropriately. With regards also to patient flow, with these times, what we are doing at Gum Docs is we're making sure that we don't have too many patients sort of overlapped. So we have their patients and their rides wait in their cars until we're ready to see them. So normally we'll send them a text message or we'll call them and say, Mrs. Jones, okay, we're ready for you. Come on up. Okay. As they come up, they are 2 meters away from the front desk. There's a table there with a mask and sanitizer. We ask them to put their mask on. We ask them to sanitize their hands. Any sort of paperwork that they need to fill out is already placed on that table before they even arrive. They fill out all the necessary paperwork that they need. They keep their mask on until we are finished with them. So they are taken, once all the paperwork is done in the sense that we have their medical history if that hasn't been provided and whatnot. When they're taking, they go straight from the reception to the treatment room. They have their mask on all the time. All of the consultation or discussion with regards to the procedure is done with them having their mask on and with us having the appropriate PPE on. Obviously, when it comes time to provide the treatment, we get them to remove their mask, but whenever possible, we always make sure that they have their mask on. And again, as most of you are aware, we do that so that it protects us from any sort of aerosol that they may generate should they cough or sneeze or anything like that. We have a question. Where is this video that shows us how to put on PPE and to remove it? The video, so if you, I don't know the Alberta Dental Association College website address off the top of my head, but if you just Google Alberta Dental Association and College, it'll give you the link. When you go to the link, just follow the COVID-19 link, and then there is a link there that says that the appropriate donning and doffing of PPE. And once you click that link, it'll take you to the video that you are looking for. So the patient, we get the patient to keep their mask on at all times as much as possible. Stagger the appointment time. So if we see a patient at 9 o'clock, then we treat the patient, but then we have, a break in between the patients just to make sure it gives our team time to disinfect everything, and also gives us the opportunity to make sure that the same patients or the same patients' rides don't overlap. We also do not use the same room again for another 3 hours, okay? There's no real guidelines with regards to how long it takes the aerosol to dissipate and whatnot, but we're trying to do the best that we can to make sure that we minimize any possibility of any sort of contamination. The other important point is when you bring the patient into your treatment rooms, most offices, will have magazines, or if you have a TV, they might have a remote control or something like that. It's really important to remove as much as you can out of the operatory, especially if you're creating an aerosol, okay? All of our paperwork and everything, once we are ready to go, is taken out of the room into a separate room so that if there's any aerosols created, we're not getting those aerosols to land on their chart or their discharge paperwork or anything like that. So whatever you can remove from the operatory or the waiting area that is not essential is important. The question is, the 3 hours in between ops, are they only for aerosol producing treatment? So ideally, yes, because that's what we're guarding against, but because we have the treatment rooms, we are doing this whether we generate an aerosol or not. Because we have the luxury of having multiple rooms, whether the treatment creates aerosols or not, we still shut that room down for 3 hours. The next question is the 3 hour wait. Is this even if the patient is negative? And the answer to that is yes. We are doing that currently because the patient may say no or be negative to all of the symptoms or risk factors, but yet they could be asymptomatic. We just don't know. So even though we're following the standard, we're trying to follow a higher standard just to make sure that we protect ourselves and our staff, and to make sure that we don't jeopardize the health of other patients or anybody around that. So because right now we have the room, we are doing that 3 hour wait, whether the patient is positive or negative or anything. Consent forms. With the COVID-19 situation, we're trying to make sure that we minimize liability with regards to treating patients, with regards to the staff treating patients and whatnot. So these are the consent forms that we have the patient attest to. In a nutshell, they have the COVID-19 symptoms and risk factors. We want to make sure that they read through and certify that they do not have any of these signs or symptoms, okay, just to cover us from a medical legal liability situation as well. As well, we have a similar form for the staff. So every time I go in to see emergency patients, I fill out one of these forms attesting that, I haven't had a fever, I don't have a cough, I don't have a sore throat, I don't have any flu-like symptoms, I haven't been told by Ontario Health to quarantine or self-isolate or anything like that. And again, that's just from a liability perspective. I want to make sure that I don't put myself or my team members at risk. Question, do you have HEPA filters in the ops? The answer to that is no, we do not have HEPA filters in the ops. Next question, are you using, I think they're trying to say forehead thermometers, and the answer is yes, we are using forehead thermometers, which basically I believe is an infrared technology where you don't have to touch the patient, you just have to get close enough to them, and it does give us a temperature reading. Another question is, not all offices have the luxury of waiting 3 hours to use the op again. What is the protocol for those offices? Again, unfortunately, I don't have an answer to that question because there's been no guidelines established by the RCDSO with regards to situations like that. I do know that in other jurisdictions or other provinces that are seeing emergencies, they don't have any guidelines as well with regards to if you see a patient, you can't use the room after X number of hours or minutes. Okay, so currently there's been no guidelines that have been forwarded to suggest, you should shut down a room for X number of minutes or hours or whatnot. This is just something that we have developed the protocol for at Gumdocs based on, situations around the province, around the globe, and trying to sort of take a higher standard to make sure that we are not jeopardizing anyone's health. So hopefully, as the pandemic starts to taper down and we sort of get ready to go back to work, hopefully all of these guidelines will be provided to us by the RCDSO. Okay, but to answer that person's questions, no, there is nothing hard and fast telling us to wait 3 hours. This is just something that we have developed as an internal office policy. That's okay. Okay, that's the end of my little talk. I'm happy to take any questions that you may have with regards to anything that I've discussed, or if you have questions about patients, whatnot. I'm happy to answer any of them.
So there are a couple other questions that are in the chat. I can read them for you. The first one is, how precise is the infrared thermometer?
Good question. I honestly don't know the answer to that. I can't give you a percentage or anything, but it is something that is being used on the front lines. If you watch the news, a lot of airports and whatnot are using that. Again, in the past, most likely we would use a thermometer that goes into your ear to get you a temperature reading. But with the pandemic, everything is trying to switch over to a non-contact type of protocol. So the infrared thermometers or temperature gauges have taken front line because of the fact that we don't actually have to touch the patient.
Okay, the next one is, are you taking periapical radiographs?
So if we have to, I believe we have that capability, but for the majority of procedures that I'm doing, which is extractions, because that's really everything that comes down to patients opting to have the tooth removed as opposed to waiting to get endodontic treatment. So majority of my patients come with either they have a Panorex or we're taking a Panorex. But we do have the capability of taking a periapical. But if I'm doing an extraction on a particular tooth, then we just take a Panorex because it gives me more information with regards to if there's any proximity to the sinus or to the nerve or anything like that. So yeah, I could take a periapical if I needed to, but most of the times, I just need a Panorex because it's more relevant to what I'm doing. I think I saw a question there. So I got a couple more questions. What steps are taken to disinfect reception area after patient leaves and before the next one comes in? So with regards to the reception area, the receptionist that we have wears all of the PPE that we feel is appropriate. So they wear an N95 mask, they wear a hairnet, excuse me, they wear a N95 mask, a fitted mask, they wear a hairnet, they wear gloves. There is no contact. They're always 2 meters or 6 feet apart from the patient. Once the patient is done, then the desk, the reception, all that area is cleaned with TB wipes and allowed to dry. And we have at least an hour, if not an hour and a half, before the next patient comes. So we're trying to stagger them so that there's no overlap between patients and their rides. And also it gives us time to make sure that we do the appropriate disinfection to prepare for the next patient, whether it's the same day or the next day or the following day, etc. Next question. As far as you are aware of, have you had any patients refuse treatment when they read through your COVID-specific informed consent? The answer to that is no. And I believe the reason for that is we have a very strict protocol that we follow to make sure that we see the patient. So I've had patients called that want to come in to have sutures removed for various periodontal surgeries that they've had. And again, that doesn't fall under the category of emergent care. So therefore, we do not see these patients. We apologize, we make them aware of the pandemic, and we tell them that as soon as we're back, we will help them out, but we do not see these patients. So the patients that we do see are truly in pain and want to have something done. So we have not had anybody say, no, I don't like your consent form, I'm gonna go home. Next question, regarding the thermometer that is only relevant for actual symptomatic cases of COVID-19. People can be contagious for up to 3 days before being symptomatic, which is why it comes down to universal precautions. Excellent point, and that's what I had mentioned earlier in my discussion, is that a patient could be negative for everything and still be an asymptomatic COVID-19 carrier. The thermometer thing, again, is just an additional step to make sure that we follow all the necessary check boxes to try and minimize, mitigate risk, okay? So you're absolutely right. We could take the temperature of somebody that is an asymptomatic COVID-19 carrier, and their temperature could be 36 or 37, and we wouldn't have a clue that they're a carrier. So again, excellent point. We should use universal precautions. Well, that applies to everyday dental work, whether we're in a pandemic or not, right? You should be using universal precautions for everybody. Next question, why are they wearing gloves at reception? Shouldn't simple hand hygiene be effective? Yes, hand hygiene should be effective, but again, we just want to make sure that we are taking that extra step to make sure that they're wearing gloves so that they're not tempted to touch their eyes or anything like that. Again, it's just an added tool in the toolbox to make sure that we keep them safe. Next question. What's your reason for reception to wear N95 mask versus a surgical mask, given that they are not in the office? Again, good question. They would be perfectly fine wearing a surgical mask because they're not generating aerosols or anything like that. But again, we're just taking that extra step to make sure that we protect our front desk. So yeah, a surgical mask would be fine. Technically, if you follow the social distancing guidelines, they really don't need a mask. But um, again, we're just taking that extra precautions to protect our staff. Are all our surgical masks level 3? And the answer to that is yes. Even for the receptionist, yes. Let me just get through. So next question is, how often should the receptionist change their masks? I'm assuming that you mean the N95 or surgical. Again, with regards to the number of patients that you see, so if they're using a surgical mask, okay, and also part of the problem with all of this is how much PPE do you really have, okay? So if you do have, a good supplier of PPEs, especially surgical masks, then I would suggest that you probably replenish them based on the patient. So every time somebody new comes in, just change the mask. But if you are limited in the amount of PPE that you have, then it might be appropriate just to use one mask for the day or for 5 patients, depending on how many patients you see. That is something that you're going to have to judge yourself to see what are the chances that that mask has been contaminated based on the patient flow that you have. The other question, which is a good question, is do you reuse N95 masks? Can you place a surgical mask over it and change that? So as some of you may know, N95 masks are made by different companies. They come in different sizes. And the problem with the N95 is they needed to be fitted, okay? So the N95 mask that I use, okay, is a particular type made by 3M, which we do not have a ton of supply of. So when I see a patient, I wear the N95 mask, but then I use a surgical mask over top of it. And the reason I do that is because if there's any sort of contamination that is generated, then I'm hoping that the surgical mask will prevent the bulk of it from getting through to me, okay? And then I dispose of that surgical mask at the end of the treatment, and I'm trying to protect the N95, because if we run out of the N95, then I cannot provide my services, because I always use an N95 because a extraction that could look fairly straightforward could break and I may have to go surgical to get the job done. So I always treat every patient that I see as though we're going to be generating aerosols. So yes, I do double mask in that I have the N95 closest to my face, and then I have a surgical mask over top of the N95 to cover that. Also, there has been, I was going to say, but it looks like somebody has already beat me to it with regards to contamination of the N95. So what I was going to say is that there's been some trials going on with regards to trying to reuse the N95 and trying to re-sterilize the N95. They've tried hydrogen peroxide, high concentration alcohol, UV light, etc. But a lot of the chemical ones are sort of deteriorating the integrity of the mask. So the way that we're doing things is for the number of days or patients, we're cycling through the N95. So the literature is suggesting that if you have COVID, the virus can survive on various surfaces from anywhere from hours to a couple of days. So I'm not using the same mask every day. Okay, so I have a sort of like a bunch of N95 masks that I cycle through, and what I'm hoping for is that, you know, after leaving that one particular mask, you know, for 4 or 5 days, that if there is theoretically any COVID-19, that it hasn't survived past, you know, after the 4 or 5 days. I don't have any science to verify whether that's true or not, but I'm just trying to work within the confines of what we have currently. Another question is, how do you protect your neck? So basically, we have, as part of the armamentarium, we have a disposable gown that we wear, and the gown basically comes up almost to the collarbone, okay? And then as for eye protection, I actually use something that looks like a welding mask. So it has a fairly long plastic face shield, which I can lift up or drop down. So I have the face shield down very low, and I'm just going to lean forward so you can see my neck. So when I have the face shield on, when I'm working, I'm looking down like this. So the face shield actually comes down and touches my chest. Okay. So if there's any part of my neck up here that is exposed, when I look down to provide treatment to the patient, all right, my neck now is covered. Okay. So that's how I try to protect my neck from the area above where the gown would normally sit. Also, when I'm treating patients, I'm not, we have surgical scrubs at Gum Docs, so I'm not wearing the same thing over and over again. Okay, so we have sort of a double layer protection in that we have a disposable gown, and then we have surgical scrubs that are laundered for us. Next question. If we see people because they are in pain and we give them antibiotics, let's say that they will need an extraction, do you wait and see if the antibiotics, do you wait with the antibiotics, or do you schedule an extraction in the coming days? Good question. So the protocol is, if the antibiotics take them out of pain, then we do not need to see them, because if they have pain from a bad tooth, if you put them on antibiotics, that pain could be fine for weeks to months. So there's no point in trying to bring the patient in to get the extraction done. Again, we are trying to minimize the number of people that we are seeing, okay? If they have a true emergency, absolutely, we're happy to see one, we're happy to see 100. But we don't want to be seeing patients that are not in pain. So if the antibiotics or the painkillers take care of their problem, then they're technically not an emergency anymore, and they can wait it out. Hopefully, the pandemic will be over soon, and then these patients can go back to the normal routine of getting treated. Okay. However, if you put them on antibiotics and pain medications, they're fine, and then they flare up again, you could potentially put him back on another course of antibiotics, right? And if they're fine again for a while, great. If not, then this patient now becomes a patient that needs to be seen to remove the source of the problem. Next question. When we return to work, will we need N95 masks, or return only when we can use surgical masks? Again, a very good question. Now, the answer to this is just my own personal opinion of what will happen. I have no additional information as to what's going to happen. This is just my personal bias, okay? When we return to work, I think that the current guidelines for personal protective equipment will be in place. What I mean by that is, I think the RCDSO will say, if you're going to produce aerosols, then you need to have an N95 mask. If you don't produce aerosols, then you need a surgical mask. And the reason for that, I believe that's what's going to happen, is because we're not going to have an appropriate vaccine based on what people are saying for about a year to year and a half. So we're going to have to keep treating these patients as if they're COVID positive patients. Okay, so I think the N95 mask will become a requirement for any procedures where you may be generating an aerosol. Um, and for those that potentially are worried that, you know what, we're not going to have, enough N95 masks to go around, I think that's a very, very valid concern. However, I remain optimistic in that if anybody has been following the news and whatnot, Medicom, which makes surgical masks, they have a plant, I believe, in Quebec somewhere. And I remember seeing on the news that the Quebec government has given them $4 million to ramp their production lines to make N95 masks. And I believe that they are up and running they believe in around June or July. So my theory is that the supply of N95 masks will be something like the cannabis situation, where when cannabis became legalized, for the first few weeks to a month, you couldn't go to a store and buy cannabis because they would sell out so quickly. So I think it's going to be very similar. Initially, N95 masks will be difficult to get, but however, once the supply lines start to ramp up, I think that we will have more readily accessible N95 masks. Also, I've seen a news clip where there's a company in Winnipeg which apparently are in the process of manufacturing N95 masks that are reusable. So I think we're headed in the right directions. I think Canada is trying to make us self-sufficient. So I don't think, in 3-4 months, hopefully we'll have an issue with getting N95 masks to use. I think our supply lines hopefully should be up and humming by then, so that we can treat patients as if we needed N95 masks for everything. But again, that's just my thoughts. Can you wear loops while wearing a face shield? The answer to that is yes. I don't have a picture of the face shield that we have, but the face shield doesn't, like, I wear glasses, so I wear glasses under my face shield. So unless your loops are really long, which may prevent the face shield from coming down all the way, but if you have standard loops, right, then I think you should be able to wear a face shield. And like I say, I would prefer a face shield over anything else because it provides more protection for your face. Same question, can you wear loops while wearing a face shield? Does your visor fit over your magnification loops? Is there a reflection of the visor? I don't wear magnification loops, so I can't answer the question about if there's reflection from the visor. I also don't wear a headlight. I use the overhead light. I don't know about any reflection issues. What is the name of the manufacturers for the visor? I don't know over the top of my head, but again, what you need to be aware of, that you can buy disposable visors, but you could also, run down to your local Home Depot and get one of those welding visors, that you can put together. And you probably want to buy, I don't know, 2 or 3 or 4, depending on how many patients you see, because what you can do is you can use a fairly strong antiseptic wipe, like TB wipes or something, and you just get just wipe down your face shield, the headband, the knobs, everything that you possibly can wipe down, and then leave that to dry for an hour or 2 or 3, and then you can use your other visor or shield for other patients. Okay, so if you can't get a hold of disposable visors, you can probably outfit yourself with something that you can reuse with the appropriate cleaning procedure. So without an N95 supply, we should only provide non-aerosol treatment without high volume suction. So the answer to that is, based on what the RCDO is saying, the answer to that is no. You can provide treatment. So nowhere in the RCDO guidelines do they say that if you're using a high volume suction, you need an N95 mask. Okay, their guidelines mainly is that if you are generating aerosols, right? Which I think they're more or less saying if you're drilling into a tooth or using a cavitron or something like that, then yes, you should have an N95. But if you don't have an N95 and you're doing something that's not going to generate a lot of aerosols, then you may be able to provide that with a surgical mask. But ideally, yes, if you're using a high volume suction, ideally you should have an N95, yes. Have you heard how people that use microscopes can handle this face shields? Honestly, I have not. I'm not sure. I'm not sure you'd be able to use a face shield with a microscope, because the face shield probably wouldn't let you get close enough to the microscope to be able to get a good view. With using microscopes, my guess would be you would have to use safety glasses that are fairly thin, because if they're too big or too bulky, again, it's going to increase the distance between the lens piece for the microscope to your eyeballs. So you're going to have to use something like safety glasses that are fairly thin and protective, so that you can get as close to the lens piece for the microscope as possible. There are dentists that are using P100 respirators, the ones used for construction. Do they need to be fitted as well? So the answer to that is yes, they should be fitted as well, because you want to make sure that the respirator is tight enough around your face to make sure you don't have any leaks. Okay, so yes, ideally they should be fitted in order to make sure that that particular respirator fits your face shape. Okay, so the answer to that would be ideally yes. If you're using a P100 respirator, it should be fitted to make sure that that particular type of respirator fits your face, because some of them are adjustable, but if your face is of a different contortion, no matter how much you tighten the bands, you may not get a tight enough seal. I believe those are all the questions. Oh, hang on. Another question. Orem Group Lab is fabricating custom frames to sit over surgical mask. Can this replace N95 masks? I don't know the answer to that, because I don't know what a custom frame is. The difference between a surgical mask and an N95 mask is the amount of particle size that gets through. So I'm not sure if these custom frames, what type of filtration systems they use. So I honestly don't know the answer to that, because I don't know if they're making a custom frame that just fits around your face. Like there's a lot of YouTube videos on how to make your own N95 mask. They're printing the plastic part of the outline of the mask, but they're using surgical mask as the filter, which again defeats the purpose of an N95. So I'm sorry, but I don't know the answer to that question. Custom frame provides a better seal on the sides. So if I can picture the custom frame, if it gives you a better seal on the sides, that's great. But the reason for the N95 is because of the particle size that it filters out. A surgical mask doesn't filter out the smaller particles. They're more prone for sort of bigger particles and larger droplets. So if the custom frame can provide the same material as the N95 mask material, then I'm sure once it's fit tested, you should be able to use it. But it has to be equivalent to a Canada Health approved N95 mask or its equivalent. Next question: where can we get fitted for N95 mask? So I know that well, I know there is a whole bunch of dentists that were seen at gum docs to get N95 masks fitted. I believe that there was um, a joint sort of um, coordination between the Ontario Dental Society and gum docs to get it fitted. I forget the name of the company that was doing it, but one of the participants has just said that Levitt Safety can fit your N95 mask. Another one is Antares, spelled Antares, and it's apparently it's $75 for a fit test for an individual. If you want more information of the company that we were using, again, oh, sorry, my apologies. Antares is the address for Levitt Safety, not another company. My apologies. I was just going to say is the company that we used, I forget their name, but you guys can reach out to Sean.
It's
Sorry, go
sorry.
ahead.
It's actually called Blue Metric. So we can also, yeah, I can send that information over as well after
Yeah.
this.
Okay. And I just want to remind that, to meet the RCDSO guidelines, you need to have a fit tested N95. They actually give you a card that you need to have. So if you are thinking of getting an N95, make sure that that you get it fit tested. The contact information for Blue Metric, it was just forwarded to me. So the telephone number for Blue Metric is 613-809-5272. That's 613-809-5272. Thank you, Dr. Jones, for sharing that contact with me. What else we got question-wise? Dr. Silver has just mentioned that you can also pre-order your N95 from Levitt. So it's a 3M brand. Thank you, Dr. Silver, for that information. So a question is, so when you get fit tested, do they bring their own N95 to get fit tested? So the answer to that is no. So normally we get, from what I recall, you have to bring your own N95 to get fit tested to make sure that you have a good seal. The downside to that is if you only have one particular type of N95, if that mask does not fit your face, then you're sort of stuck. Blue Metric, I believe, does have other types of N95s. Whether they have a huge supply to sell you or that I don't know. But you can certainly reach out to them to find out exactly what they have available. But yes, just because you have an N95 mask doesn't mean that you're going to be able to use it, because that mask has to fit your face. Okay, so that's why the fit testing is important, because I know for me to use an N95, it has to be a 3M 8210, right? So I can't use the other ones that we have. So yes, you need to have it fitted so that you know what type and what brand fits your face shape. Next question. For businesses that have multiple practices in it, like gum docs, how will treatments be done? For example, certain practices working certain days? Excellent question. Again, a lot of this will depend on what the RCDSO establishes as guidelines with regards to what happens. So that'll really determine, where we go. Outside of the N95 mask, my personal opinion is that the other factor that's going to be really important is aerosol mitigation. And what I mean by that is, how important is it to wait X number of time or X meters before you see the next patient? So if you have a closed room, right, then the aerosol that you generate, you can close the door, and hopefully with X amount of time, the aerosols will settle, and then you can re-sterilize or not sterilize, but re-sanitize your rooms to see the next patient. but a lot of dental offices are not closed, right? They have more or less partition walls that keep the chairs separate. So I don't know what the RCDSO is going to mandate with regards to that. So if they say that, yeah, you can see patients as long as they're 2 meters apart, right, then you may be able to see as many patients as you want based on the number of chairs that you have. But if they say that you need to treat a patient and wait an hour or 2 hours or 20 hours or whatever they come up with, then that's going to be the impediment, because now, unless you have endless number of chairs, you're going to be limited by the number of chairs or office operatories you have to see patients. So again, I'm not sure what the protocol at Gumdocs would be. To be honest, we haven't discussed it. I'm sure this will be part of our discussions as more information has become available from the RCDSO with regards to the guidelines. But I could very well envision that, not all practitioners will be working all the time. If we can, for example, say only use half the number of chairs that we have, then obviously not all of us will be able to work at the same time. So a very good question, but it'll depend basically on what the RCDSO provides as guidelines. I honestly don't feel that the PPE will be an issue. I personally feel that the aerosol mitigation is what's going to be the issue, because if they do mandate that you have to shut down a room after doing a procedure for X number of time, that's going to be the biggest impediment to get around. I understand N95 masks come in different sizes. How do we know what size to order? Excellent question. Again, I don't know the answer to that. Your best bet would be to reach out to one of these companies that does the fitting to see what they recommend. I know when I got fitted, the lady from Blue Metric had, I think, 3 or 4 different brands, and I failed the first 2, but I passed on the 3rd one that I tried. So I really don't know the answer to that. You're best to reach out to the professionals that do this for a living to figure out what type of mask you may want to order. So I don't know the answer to that, sorry. Dr. Silver says, it's a pre-order. You get put in the queue and notified when the shipment will be released and shipped. I believe she's trying to say with regards to the ordering of N95 masks. The next question is, will you be buying any of the aerosol reduction units? Good question. Unfortunately, right now, it's probably a bit premature, in my opinion, to decide on whether you're going to be buying these aerosol reduction units or not. And what I mean by that is, these are not simple units to just, it's not like one of those air purifiers you buy at Costco that has a HEPA filter where you just plug it into your operatory and everything is fine. No, there is some infrastructure that you potentially would require to get this, because remember, to reduce the aerosols, you have to collect the aerosol and then somehow you have to vent that to the outside world. So whether that means that you suck up the aerosol and then it goes into your HVAC in the outflow air to the outside, or whether you have a specialized opening in your office where vent it to the outside. So these might require some physical adjustments to your current ventilation system, which I'm sure is not going to be cheap. So my biggest concern is right now is that if we had an idea of what the aerosol mitigation requirements were or are, then yes, we could start talking about reduction units and whatnot. But until we can get an idea of what these mitigation procedures are going to be, it's hard to say. For example, say that they say you can use a room, but then you have to shut it down for the rest of the day. Worst case scenario, okay? And to put in these aerosol reduction units, costs $100,000 for your office. The question then becomes is, do you spend $100,000 knowing that you need to have this done? But then what you have to weigh against that is, if a vaccine is developed in a year or 18 months or 6 months, who knows? Or if they come up with an effective treatment where drug X and Y work really well to help people get over COVID-19, then maybe these restrictions will be lifted in 6 months. So do you put in the $100,000 now to retrofit your office, or for 6 months, or could it be a year, or could be a year and a half, right? There's still a lot of unknowns out there. So, my answer to that is, will I be, if it was my practice, would I be buying an aerosol reduction unit? My answer to that would be, right now, would be no, because I don't know what the specs required are. I don't know what the aerosol mitigation requirements are. Once there is more information about that from the college, then certainly, that might be something that, we can discuss. But again, all of this comes down to dollars and cents, in that, dental offices, yeah, we're a medical facility, but we're also a small business. So, you need to sort of look at the risk benefit of how much do you want to spend to mitigate aerosols, and for how long. Next question. Can metronidazole be added to any antibiotics such as azithromycin, for example? And the answer to that is yes. The unique properties of metronidazole is that it only works on anaerobes. It does not work on aerobic bacteria. But the beauty of metronidazole is it gives you a very good broad spectrum coverage of anaerobes, both gram-positive and gram-negative. So metronidazole, comes with its own risks, in the sense that, it can darken your urine or your feces. It can give some people metallic taste. Obviously you can't have alcohol with metronidazole. So it does come with some limitations, but yes, you can add metronidazole to any antibiotic you want, if you deem it necessary. Next question. When I bought my clinic, it was built with carpeting in the main hallways. What danger does this present? How urgent do you feel it is to change the flooring surface? Good question. I'm not, again, based on the current evidence, nobody knows for sure, how long the COVID-19 virus, lasts on particular surfaces. Okay. With regards to the carpeting, I don't know how big your office is. I don't know how much it would cost you to change all of your flooring. Before you start to sort of make some major changes to that, okay, what I might suggest is, if you want to be, more thorough, maybe what you need to do is, maybe you need to carpet clean a bit more frequently than you normally would, okay? Because you have to realize that you can't make every surface, sterile, right? I mean, the best you can do is try and decrease the chances of any cross-contamination as best as you can, right? So, I wouldn't rush out to change your carpet. Maybe if you're concerned that the carpet may be an issue, maybe you need to get those carpet cleaners with those chemicals in, once a week or once every 2 weeks, depending on how much flow you have in that particular area, okay? That would be my suggestion. Again, wait to see what the guidelines come out, okay? Because that will help you decipher, how aggressive you need to be. If your carpets are good right now, don't incur the cost of changing them unless you know what the requirements are going to be, okay? Unless you're going to be changing them anyway, then sure, you can do that, but I wouldn't change them right now just because of COVID. Wait and see what happens. Will you be starting a study club? The study club, I think, is going to be put on hold right now until we can get back to business. So we'll have to wait and see what happens, okay? But once things kind of normalize, we'll have more information. Question, azithromycin is bacteriostatic, metronidazole is bactericidal. I don't think you can combine the two. So that is a good point, okay, that azithromycin is bacteriostatic, but some of the bacteriostatic antibiotics in higher concentrations become bactericidal. The other thing you have to remember here is that azithromycin, for the most part, is used to take care of the aerobic gram-positive bacteria, which metronidazole doesn't touch, okay? So azithromycin is mostly used to cover the gram-positive aerobes. Metronidazole strictly looks after gram-positive and gram-negative anaerobes, okay? So azithromycin and metronidazole are not normal combinations. However, I don't see an indication or a counter indication not to prescribe them together if you wanted to. It's not a normal combination, but it's not, there is no wrong if you decided to do that, because like I said, clindamycin, azithromycin, all of those antibiotics are targeted at aerobes, not anaerobes. Clindamycin does have some anaerobic coverage, just like penicillin does. But what metronidazole brings to the table is it covers the other anaerobes that these other antibiotics do not cover. Metronidazole gives you the most anaerobic coverage. Question is, when do you expect non-essential treatment like hygiene to come back? You know what? I have no idea. Obviously, it's a moving target. If I were to make a guess, based on the fact that, in Ontario, we're flattening the curve, they were expecting 80,000 cases, and looks like we're going to get around 20,000. I would say that my gut feel is that we probably might be back end of June, beginning of July. That's my guess. That's my guess. Again, just based on what I've been reading and looking at the numbers and stuff, my guess would be, end of June, maybe beginning of July. Okay. Next question. If clindamycin is not effective for a patient, what would you prescribe as an alternative? I'm going to make the assumption that the patient has either tried beta-lactam like penicillin-based before and failed, or is penicillin-based antibiotic allergic. So if clindamycin is not effective, then my third line, so just to reiterate, my first line is always a penicillin type of antibiotic. If they have a contraindication to a penicillin type antibiotic, then my next line is clindamycin. And then if clindamycin is not appropriate, my third line is a macrolide. My preference is Biaxin over azithromycin. Okay. And if that is contraindicated for whatever reason, then my fourth line is something like Levaquin, the fluoroquinolone Levaquin, levofloxacin. Good. I have a comment from one of the participants. The Premier said today, not everything will open at once. I think we can expect to be one of the later industries to get back to work based on transmissibility issues. And I agree with that 100%, because we're at the highest risk, because we're in quote unquote people's faces. I agree with that comment that we will be one of the last ones to get back. I believe the Premier yesterday or day before said most likely people that work outdoors will be the first ones back, because they have the ability to social distance, and the fact that they're outside, so there's a much bigger sort of ventilation. But I agree with that comment that, we probably are going to be, one of the probably last ones to get back, just because of the fact that we're at the highest risk because of the nature of our work. Okay, no more questions. I want to, got another one. If a patient phones in with extra oral facial swelling, do you still go to your first line beta-lactamase antibiotic and add, say, metronidazole? The answer to that is 100%. Anytime, for whatever reason, I need to prescribe an antibiotic, okay, my first line is always a penicillin-based antibiotic with possibly metronidazole. So I add metronidazole. For example, if a patient started developing symptoms, today, I would probably just prescribe a penicillin-based antibiotic. based on the history. However, if they call me and they say, hey, doc, I started to have pain 5 days ago, then I would most likely prescribe a penicillin-based antibiotic with metronidazole. So if someone's going to ask, well, why do you do that? The reason I do that, initially with a dental infection, most of your microorganisms are gram-positive aerobes. The further along you get, it starts to switch to gram-negative and anaerobes, okay? So if they've already been having issues for 5 days, we're already starting to swing into that anaerobic area. So if it's something serious like extraoral facial swelling, then I would automatically add the metronidazole just to make sure that we contain this, because if you don't contain it, that extraoral facial swelling, depending on where it is, okay, can go to a dangerous space or a dangerous location. So I always try and manage what type of antibiotics I prescribe based on the history of the problem. So like I said, if it just started today, I think penicillin is, or a penicillin type is a great option. You know, if it happened a week ago or whatever, then you're better off to try and combine the two. Caveat with that is, if it's something minor where they don't feel like you don't feel like it's anything serious, then you could certainly try just the penicillin base itself and just keep in touch with the patient. And if you think that they're starting to slide, you could add metronidazole, you know, subsequently. But again, a lot of that is just based on the clinical situation that presents. What is your script for metronidazole? Again, as I had mentioned before, if I'm prescribing, I normally just prescribe amoxicillin just because it's a bit easier for the patient because they can take it with food, unlike penicillin. So if I prescribe amoxicillin, I would prescribe Amox 500 3 times a day, and the exact same 500 3 times a day for metronidazole. However, if you prefer penicillin VK, which is perfectly fine, then depending on the seriousness of the infection, I would prescribe penicillin 300 or penicillin 600 milligrams 4 times a day. And for the metronidazole, I would prescribe metronidazole 500 milligrams twice a day, so they can alternate with the penicillin dose. I wouldn't prescribe metronidazole 3 times a day with penicillin 4 times a day, because then it becomes confusing for the patient as when they need to manage their antibiotic intake. So I can certainly switch up the penicillin with the metronidazole twice a day. You got another question with regards to the aerosol mitigation. Again, wait and see what happens out there with regards to the guidelines. If you need to mitigate the the outline of your office or the construction of your office, I'm sure that there'll be companies out there that are going to be helpful for you. I certainly know at Gumdocs, we use Jones Brothers Constructions to, do all our renovations. So, I'm sure there's big companies out there that are going to be able to help you design your flow and whatnot. So, but I would just hold off for now. Wait to see what happens with regards to potential guidelines first before you start to, make physical changes in your office. Question. So metronidazole is still at same dose of 500 milligrams, whether it's BID or TID? And the answer to that is yes. It's the same dose, 500 milligrams BID or TID. Okay. Well, I want to thank everybody for attending. I hope you found this webinar or discussion helpful. If you have further questions outside of this webinar, you can please forward those questions to Sean, and I'm sure Sean will forward them to me, and I'll come back to you with an answer. I want to thank you again for taking time to share some time with me this afternoon, and stay safe. Okay, bye. Sean, I'm leaving the meeting now, okay?
Yep, that's all good.
Okay, thanks a lot, Sean. I appreciate your help, buddy.
Yeah, thank you. I think
Okay.
that went very well.
All right. Okay, thanks, bud. Bye.
All right, talk to you later. Bye.